Hello everyone present here. Let me walk you through a case for the approach of a case of retinal vasculitis through a resident's eye, what you should and what you should not miss. Myself, Dr. GENICKSON JEYARAJ, PG resident, AIIMS Bhubaneswar. Retinal vasculitis is an inflammatory disease of the blood vessels of the retina that may be associated with primary ocular conditions or with inflammatory or infectious disease in other parts of the body. So here, I'm presenting a 21-year-old male with complaints of painless diminution of vision in the left eye. He had a positive history of contact with a tuberculosis case, and on examination, his vision was 1/60 with no improvement in the left eye, and color vision was 1/25 in the left eye, and there was no relative afferent pupillary defect, and the anterior chambers showed plus 0.5 cells. On fundus examination, the right side fundus was normal, and the left side fundus showed the disc being normal, and the infratemporal arcade of vein that showed superficial hemorrhages, exudates, and perivascular infiltrates. And macular edema with exudates in the form of macular star was also seen. So, coming with this clinical picture, the clinical picture and the diagnosis, see, these are the clinical pictures that I got. That is vision loss, macular star, sectorial superficial retinal hemorrhages, perivascular infiltrates, exudation, and leakage. So what all the differential diagnoses that I could think as a first-year resident? So first that came into my mind, it could be a branch retinal vein occlusion because there was sectorial superficial retinal hemorrhages. Then I went on to my seniors where they had combined the vision loss with the macular star, and they told it might be neuroretinitis too. But optic disc swelling was missing. So finally we went up to the faculty, and there they gave us the diagnosis of retinal vasculitis. And then we sent the patient for a battery of investigations with a routine blood test, and a Mantoux test was done, which came out to be strongly positive. A chest X-ray was done, which was clear, and a syphilis serology was also done. And the patient was treated with corticosteroids, anti-tubercular therapy, and on follow-up, the patient has developed a tractional retinal detachment. So for that, scatter laser treatment was done. After 2 months of follow-up, the patient developed vision in the left eye to 6/9, and the color vision was improved to 25/25, and there is no RAPD, and the anterior chamber is square. You can very well see there is decrease in the inflammation in the fundus. So, as a resident, what are you supposed to look for in a case of retinal vasculitis? First, it is the type of vessel, then the size of the vessel, the morphology of the perivascular infiltrate, and any associated ocular signs. Coming to the type of vessel, it could be either the artery, vein, or involvement of the bone. In case of an artery, it could be idiopathic retinal vasculitis, aneurysm, and neuroretinitis associated syndrome, or it could be systemic lupus erythematosus, or it could be polyarteritis nodosa. These are few examples that I'm giving you, which are commonly seen. And when it comes to a vein, it could be tuberculosis, Eales disease, which is a hypersensitivity to tuberculosis, or sarcoidosis, or it could be Behçet's disease too. When it involves both artery and vein, it could be ANCA-associated disorders like granulomatous with polyangiitis and frosted branch angiitis. Coming to specific perivascular infiltrative morphology, like hyaline plaques, which are whitish segmental plaques that can be seen in infective etiologies like CMV retinitis, and in toxoplasma and TB retinal vasculitis. And frosted branch angiitis could also be seen in most commonly in CMV retinitis. And associated ocular signs. In this ocular signs, the subvascular lesion could be specifically considered for a case of TB retinitis or a TB retinal vasculitis. Candleback drippings can be seen in cases of sarcoidosis.
Try to wind up, please.
Yes, ma'am. So coming up to the investigations, fundus fluorescent angiography is a must in these cases, and if you are suspecting a specific etiology, then you can go for specific investigations. And the treatment protocol also includes control of the infection, control of the inflammation, and ancillary treatment for any complications during the follow-up. So the take-home message is distinguish the type of vessel involved and the morphology of a perivascular infiltrate, to look out for the associated ocular or systemic signs, to perform specific blood investigation when a strong etiology is suspected, and to treat based on the detection of an associated condition and the severity of the disease. Thank you.
Very good. Can you start the next presentation? Doctor, one question for you. I think your Mantoux was positive and
Yes,
your TB Gold was also positive.
Yes.
Was it done, TB Gold?
Quantiferal
Okay.
TB Gold was not done, ma'am.
So was he treated with ATT? Anti-tubercular therapy was given?
Ma'am,
Okay.
ATT was given
ATT was given.
just on MAN 2.
Yes.
Just
We have done a presumptive diagnosis of ocular tuberculosis and we have started.
Because I had one patient where MAN 2 was positive, quantiferon TB was positive, still physician did not treat because there was no symptom.
No, see, that's a whole new, I mean, that the whole session is required for discussion. But to start TB treatment, we don't need a positive Mantux, we don't need a positive TB gold, we just need a suggestive clinical picture. That's it. So the physician has no business to refuse starting ATT if you want it.
Okay.
You have to change the physician, that's all.
Thank you.
Thank you.
Dr. Shivani, please.
Good afternoon. Good afternoon, everyone. Today I am presenting a case of a 20-year-old male presented in our OPD. Good afternoon, everyone. Today I am presenting a case of a 20-year-old male presented in our OPD with a chief complaint of sudden diminution of vision in the right eye for 1 day. Diminution of vision was marked, painless in nature, and patient experienced mild blurring of vision in the right eye since last 10 days, but the patient ignored the symptoms. There was a positive history of hematuria, 4 episodes in the last 6 months. There was no significant personal history. For hematuria, patient was treated with tablet norfloxacin plus tinidazole combination 2 months back.